So we're continuing our lectures on valvular heart diseases. So here we're going to primarily focus on aortic stenosis, right? So we're going to talk about what is the disease? We're going to talk about the aortic, right? Aortic stenosis. Now, that means that the aortic valve that has been thickened, right? And it's having very difficult to open up. And this is what valve is. So you can see this is a left atrium and this is a left ventricle, okay? I did not draw the right side of the heart because we're going to primarily focus on this valve, which is a aortic valve, and it is a three-cusp valve, okay? So usually the blood has to go this directions. Now, what is we have to talk about the aortic stenosis, the etiology or causes, right? What can lead into this thickening of the heart diseases? And we can divide it into two categories actually. We can say one could be congenital, right? This could be a congenital or it could be acquired, right? And you need to know both of them. And this is one of the most common valvular heart disease that you see. And when you're doing your internal medicine rotations, you might even see patients, or specifically when you do your cardiology rotation, you'll see, all right? And congenital heart disease, or it could be acquired. Congenital heart disease could be caused by a couple of reasons. One is something called, bicuspid, okay, bicuspid aortic valve, right? Bicuspid aortic valve. Or there's other conditions, like for example, sometimes there's unicuspid is there too, or there's also like a tricuspid or tetracuspid also there. But I really want you to remember one though for your exam, and that is something called bicuspid aortic valve. This is a very high yield, all right? Another one, like when it comes to acquired, we usually say this is more of like, it could be let's just say degenerative, all right? And this has to do with the age, very, very important. Or sometimes you can also get this caused by, all right? Usually it can be caused by something called acute rheumatic fever, right? That could be the cause. Now, these two are the most important for your board exams, and you need to remember, like bicuspid aortic valve and degenerative, okay? And usually what you should remember is this, that, as I said, the aortic valve is what? Aortic valve is normal first, right? Usually it is like this, all right? What is this? So these are 1 here, 2 here, 3 here, right? What is this? This is it has a three cusp, right? And around down here, this is what you call them commissars, right? This is what is called commissars. Usually commissar is anchoring your leaflet, and these are the leaflet, right? The leaflet. So commissar is anchoring this leaflet on the wall, right? That's what they're doing. Now, whenever, in normal first, whenever, the left ventricle contracts, it generates higher pressure, more than 80 millimeters of mercury, correct? And when they do that, what really happens is the aortic valve opens up, right? And it propels the blood out. That's what it does. Now, and then after that, what happens, the aortic valve closes, right? And it doesn't allow the blood to come back. But usually sometimes what happens is that in congenital, some people are born with, because these commissures, they become very, very fibrous, right? And this appears as just a one valve. So this 3 and 2 just appears as a one valve. So you have only this valve is open and this valve. So you have only 2 valves there. So maybe I can just make it like this. And it's supposed to be 3, but it will appear as this. Like only there's a 1 and 2 valve is there. That's what we call them a bicuspid aortic valve is there, right? And usually when this happens, every time, mitral valve opens and closes, right? That causes, over the period of time, that causes something called wear and tear lesions, right? So let's write down here. Both the conditions leading to something called wear and tear, okay? Tear lesions. And in both the cases, like for example, even in the degenerative conditions or even the aortic valve, really what happens is that there's a mechanical stress on the aortic valve every time when they open and closes, right? And that results into some sort of micro hemorrhages, or like basically micro tears in the aortic valve here. And it's because of this really what happens, that leading to chronic inflammations, right? That lead into chronic inflammations. And from like your, pathology, chronic inflammations, really what happens is, as this get all wear and tear, slowly what happens is this, because of the inflammation, there will be a increase of like a collagens getting deposited there on your valve, plus, right? Plus a lot of like, calcium gets deposited into this. And whenever a lot of this abnormal amount of calcium that is started getting deposited in there, right? Calcium will basically bound or get precipitated with the phosphate, and they form something called crystalline calcium phosphate, right? And whenever you see the crystalline calcium phosphate, right, abnormally present in this valve, then we call them what? We call them calcifications. So this is what happens, all right? So the ultimate result is this, that, there is a fibrosis, right? Fibrosis and calcifications of the aortic valve happens, all right? And what kind of calcification is this? This is a dystrophic calcifications, okay? This is a dystrophic calcifications. Now, I want you to remember something, that, the way you can distinguish whether it is caused by, let's just say, bicuspid or degenerative, right? You should look at the age of the person. Usually, the degenerative is age related. So, in this case, right, please remember this. In the degenerative, you see a fibrosis and a dystrophic calcifications of the aortic valve, but you see that in a patients that are greater than 60 years old, all right? And this is the age is very important. Whenever you're reading a clinical video, make sure you look at the age of the person, right? When we talk about the bicuspid aortic valve, usually this is a middle age. And for the bicuspid valve, I'll write down here, less than 60 years old or primary, we'll say like 50, or let's just say, to be safe, we'll say less than like 55 years old, okay? Usually patient will present to clinic with like 50 years old, like middle-aged people will have something called bicuspid aortic valve, because over the long time, right, this lead into chronic inflammations, and these guys will, the commissure will fuse. This is the pathophysiology of this is the, commissure will fuse actually, right? Commissure will fuse, and that lead into what? The commissure will fuse this, and that makes that lead into what? Mitral valve does not open properly. So that's called stenotic valve. This pathophysiology, this has to do with the degenerative, all right? So what I want you to remember is that the degenerative is this one, and usually degenerative lead into something called dystrophic calcifications, right? So this is very, very important. Okay, fibrosis and calcifications in people with older age. This is what? Degenerative of it. And you can remember what the bicuspid aortic valve happens because there's a commissure will fuse, result into bicusp, right? And that causes what? The valve to have a difficulty to open up, right? And please remember, commissure will fuse and degenerative, please remember fibrosis and calcification get deposited into the aortic valve, making your aortic valve very, very thickened, right? This is something that you've got to remember, and make sure you remember the age of the person, all right? Again, bicuspid is much more what? In middle-aged people. When you talk about the age-related degenerative, it's older people, like 60 years old. Sometimes they even say like 90 years old, right? And usually this is one of the most common like valvular disease that you see. Now, the acute rheumatic fever, right? That can lead into the aortic stenosis, but it's not common specifically in US or like developed countries. It used to be common like a long time ago, but it can still be common in like other parts of the countries, like for example, developing countries, like in India or so. The reason why is because developing countries may not, they don't have a proper treatments for someone with a if they have a pharyngitis that is caused by group A streptococcal, right? That result, they produce something called AM proteins, and that do cause reacts. And that causes an acute rheumatic fever, and that can lead into something called aortic stenosis. But to be very, very for your board exam, what I want you to remember is the rheumatic, like a fever, acute rheumatic fever. I want you to associate that with the mitral valve, because it's always the mitral valve it targets first, the acute rheumatic fever. Then after that, it can involve aorta, right? So with the acute rheumatic fever, I want you to remember the mitral valve first, and then after that you can think about the aorta. But these two, you must remember the degenerative and the bicuspid aortic valve is the most you got to remember. And please look at the age, and I explain you why this happens, right? And usually it targets, right? It usually targets this fibrosis that you see in an area where there is something called valvular. These valvular fissures are there, or sometimes we also call them valvular fibrosis there, okay? And please remember this one too. This one you got to remember, and please remember the fibrosis and calcifications that happens aortic valve in the degenerative or age-related, and please remember the commissural fuse and the bicuspid aortic valve, right? And that can result into what? Aortic stenosis. You've got to remember that. You've got to remember this because that's how they'll ask you. Now, after this, what is the most important thing is like, this is a vagus diagram, right? And this is what very important that you got to remember. Let's draw the vagus diagram normally, right? Usually what happens is that when let's just say in the atria, when the left ventricle contracts, right? What is the contraction happening? If you look at the pressure volume loop graph here, right? This is what the mitral valve opens up, mitral valve closes, correct? And here, contraction is happening here, ejection is happening. This is all ejection. Slow ejection is happening here, right? And this is what relaxation happens. This phase, from here, you have a relaxer diastole, right? This, that's a contraction phase there, right? This is where what happens, the mitral valve closes, correct? And this is the phase where the atrial contraction happens, right? So whenever we draw, like let's just say the pressure, what is the normal pressure in aorta? In atrium is what, about 10 millimeter mercury, right? So whenever the atria contract, it basically makes a little bit of pressure like this, right? And this is called A wave. And then after that, what really happens is that, when the ventricles start contracting, some of the blood try to go back to this mitral valve right here, right? The mitral valve, and what happens is that causes that makes a little blip, right? Mechanical blip, and that is usually denoted by this graph, right? And this is what is called A, and this is called C, right? Then after that, once that mitral valve closes, what happens is that mitral valve will work as basically a storage for receiving of blood, and you continue seeing graph like this, right? As they receive the blood, this is what a mitral valve looks like. It goes like this, right? And then later, when the mitral valve opens up, blood again comes back like here, right? Like this, right? So this is what you see in the pressure when it comes to the left atrium, and this is normal, right? And when let's just say ventricle contracts, right? Initially what happens is that, when the ventricle is relaxing and when the atria is contracting, the ventricular pressure is lower than atrial pressure, right? It's like this. Then after that, what happens is that when the ventricle started contracting, the pressure started going up like this, right? The pressure started going up all the way up to like goes up like here. And it opens here around like 80 millimeter mercury, right? Because aortic pressure is normally what? This aortic valve gets open, let's just say for example, this 80, right? It becomes 80.1. That's where the aortic valve opens up. And then after that, this is what 80 millimeter, right? This is what the aortic valve opens up right here. Then the continues going up all the way to 120 millimeter mercury, right? So it goes all the way down to keep going up all the way down to let's just say this one right here, right? It goes all the way down to, and then after that it falls down like this, right? So I can make, actually, I'll make this a little beautifully so that you don't get confused. So it goes like this, and then 120, and it falls like this, right? Falls, and after that, what? This is slow ejection phase, and after it continue falling down, and it goes all the way down, and it comes below this what? Below this aortic pressure, right? It always comes below the aortic pressure. You've got to remember this, all right? There's the importance of this little detail, all right? Now, this is how normally what your ventricular pressure looks like, right? Then normal, what about normal atrial pressure? Normal atrial pressure, usually aortic valve closes around here, right? This is your 80 millimeter mercury. This is about the average, like about 100 or something, right? So here it all closes, right? So the aortic valve closes around this directions. So that means that usually this comes down here, right? Like this, okay? That's what happens. And this is the pressures of the left atrium. And this, when there was an increase in cardiac output, when the ejection is going on, right? This also, aortic pressure also, as the receiving blood, it also started going up like this, correct? This is what happens. And then after that, when the slow ejection phase is happening, the aortic pressure also started coming down here, right? As they're coming down here, around let's just say, like 100 around here, right? When the aortic valve closes, it produces a little blip, and this is what is called dichrotic notch, okay? And this is what you see. And this is usually what? Your atrial pressure. This is what? And remember, if you look at this ventricular pressures, they're like, they're almost like synchronized with one another. They're very close to one another. Now, this is a normal physiology, this is what happens, right? And this is a very, very important, because this is how your board exam will test your concept. Now, and this is normal here. So if I make it, if I quickly make this too, right? So that way you don't get confused, like right here, right? So now this is, I said 100 at 100, right? And we can make this as 120 right here, okay? This one, and this is, we can make like a 70 right here. This one will make a 140 millimeters of mercury. This is 0, right? Now, and this is a point where we say 80 millimeter mercury, like this one. Now, when let's just now we talk about abnormal. Let's just say when the aortic valve becomes stenotic, when it becomes thickened, because a lot of calcium get deposited. Like for example, if I quickly make, let's just say we talk about degenerations, right? Let's just say this is abnormal, is there? The degeneration valve is there. Like, okay, you have this is a valve, right? And then what happens is this, that, you know, a lot of times, a lot of this, let's say calcium start getting deposited right here, okay? The calcification in fibrosis happen is because of what really happens is that this valve become very fibrous and thickened, right? And whenever it needs to contract, it would not able to what? It would not able to open. So it's because of what happens, the left ventricle has to vigorously contract and it has to generate a lot more higher pressure in order to open this valve, right? That means the pressure in the isovolumetric, that has to go really high. So that is why, you know, as this ventricle started like contracting, right? This pressure, right? This pressure, like keep going up. And from here, like it goes all the way down like right here. So it goes all the way up to like maybe like goes like 140 or something, right? It goes, that's what it goes. And when this happens, it also comes here, and this here you see the graph like this, right? It goes up and then it comes rapidly come down like this, right? And this is what you see. And this is what you see when it comes about the aortic stenosis, see? There is a what? There's the valve, the ventricle has to contract vigorously and it has to generate very, very high pressure in order to propel the blood out, right? So this is, let's just say this is a, we can simply say this A point is here, this is A, that means you have to go to A'1 to open the valve, right? This is what happens. And in that time, what is also happening here is that, look, this denoted by end systolic volume, right? And this is end diastolic volume. This is a volume and this is a pressure and volume, right? So they have to generate high pressure. That means that what pressure is really went up is that this is what ventricle is contracting here, right? Ventricles contracting here, ventricles contracting ventricle. That means that your ventricle pressure is high. And if we are talking about the left part, so that means left ventricular, right? Left ventricular pressure is very high, right? That's what it is happening. So it's going to go very high. That's one thing. And after that, this is very important, okay? On top of this, when it contracts, aortic valve is supposed to close here, but now it's going to close at much more higher pressure, also like maybe like this direction right here. So it also closes more, So it's because of this, there is a decrease in what stroke volume is there too, right? So there's a decrease. Plus then look what happens. Now this end systolic volume is right here, right? That means if this is 70, this is 140. That means let's just say this is 100. That means what happens to the end systolic volume? This is isovolemic relaxation, right? This shift to the more to the right. So that means that this end systolic volume is increased. You see that there's increase in what? Left ventricle pressure, increase in what? End systolic volume, right? Third, what do you see? What do you see is like, if you look at the normal, like let's just stroke volumes, right? What is normal stroke? What is stroke volumes? Stroke volume is equal to what? End diastolic volume minus the end systolic volume, right? And end diastolic volume is 140 minus 70. It usually gets 70 millimeter of mercury, correct? But because of this, really what happens is that there is now it's 140 and now normal is 70 millimeter mercury, right? This is normal. But now like look, the stroke end systolic volume is 100 and then this is 140 end diastolic. So when you do 140 minus 100, what do you get? You get a 100, right? So that means that there's also decrease in what stroke volume you see. 4. Look at the stroke volume. Now, what happens? Look, you could have a slight end diastolic volume would be like not much change, like normal. Usually, only in advanced condition maybe there could be a change, but usually advanced the end diastolic will be like not much change. Now, 5th is like you have to look at the ejection fraction also. And what is ejection fraction is? It's a stroke volume divided by end diastolic volume, right? And then remember, stroke volume is normally 70, right? And you do 70 divided by 140, you usually get 50%, right? But now that really what happens is that the ejection fraction is directly proportional to stroke volume, right? So if you decrease stroke volume, you also decrease in like ejection fraction. So there's ejection fraction decrease. So remember, left ventricle pressure is high, increase end systolic volume, decrease S volume, end diastolic is kind of like normal in our graph, and ejection fraction is low, right? This is how you gotta remember this, right? This is how they ask you. And I draw pressure volume loop graph to show you how things happens, right? Now on top of this, when the ventricle is contracting vigorously, right? This ventricle is contracting in high pressure. What happens is that, this ventricle started going what? Hypertrophy. This part of the ventricle, right, started becoming what? Hypertrophy. That means that what happens is that this ventricle started becoming more thickened, right? They started becoming thicker. As they become thickened, what happens is as they become more and more thickened, what really happens? That causes, the ventricle also have difficulty to relax. That's what it's become, right? So this left ventricular hypertrophy you started saying, okay? Left ventricular you see a left ventricular hypertrophy. And this type of ventricular hypertrophy, right? Usually, you got to remember this, the sarcomeres started getting, the gene expression genes happens, and they started adding in more in a parallel fashion. So that way, the sarcomeres started adding in parallel fashion, and that resulted in something called concentric hypertrophy that you started doing, because there's a pressure overload is there. And as the time goes, right, what happens as this become more and more thickened, right, what happens is they become more firm. So that means every time when the ventricles relax, what happens, and when they try to relax to accommodate the blood volume, they would not able to accommodate the blood volume here. The reason why is because the heart has become very firm and restrictive, right? And that results into a decrease in a compliant, all right? Decrease in compliant, or decrease in what? Decrease in compliant. And if you decrease in compliant, if they're not, the ventricle is not able to accommodate the blood during a relaxation, and that means that can result into something called diastolic dysfunctions, right? Diastolic dysfunction too. So this is how the pathophysiology works, right? Now, that means that whenever the pressure is overload, what really happens, the left ventricular pressure is very high, right? Plus, as the time goes, in advanced condition, there is also diastolic dysfunction. That means the pressure even goes more higher. As this pressure more goes up, what happens? The left atrial pressure is also going up because it cannot what? It cannot drain the blood into here, right? That means that this left atrial pressure is going up too. That means that what is draining the blood in here? Pulmonary vein, right? So venous pressure started going up too. So everything is backing up, leading into what? Left heart failure. And the pulmonary venous pressure goes up, everything will back it up, that leading to pulmonary congestions, right? And then what happens after the pulmonary congestions? There's a lot of fluid is actually backing up. You see that pulmonary capillaries, and then from the pulmonary capillaries, a lot of fluid is started losing or oozing out because there's an increase in what? Hydrostatic forces. Pulmonary capillary hydrostatic forces will be increased, that will result into pulmonary edema, and that can cause one of the classical conditions, what? Dyspnea, right? That can cause dyspnea. Okay, we'll come back to that. But please remember, these are the changes that you see, right? Please remember the left ventricular hypertrophy, concentric hypertrophy, all this can lead into what? Something called dysfunction, right? And the reason why is there's an aortic valve is what? Aortic valve is stenotic, and that resulting in what? Something called, there is an increase in what? Afterload is there, right? So this is what we can simply say, there's an increase in this afterload is there, right? Now in the pressure volume loop graph, how is this going to look? Look, now this is very, very important right here. You know, what are we going to do? We're going to draw, okay, I'll draw this in a green, right? You know, look, normal is this, right? Normal is it. And now I'm going to draw is that, look, this is a normal in the red, okay? What happens if this is normal? But remember, the aortic valve is stenotic. That means that it has to generate a lot more pressure. Like, so this means this is going to keep going up, keep going up, keep going up, keep going up, keep going up. It's going to keep going. And usually, look, aortic valve, look, opens at this, right, 80 millimeter marker, right? Now, because of a stenotic valve, maybe it's not opening at the 80 millimeter, maybe it's opening at, let's just say, 120 millimeter marker. So it has to go all the way down to, let's just say, maybe like here to open up, right? This is what it does. And as it's open up, what happens? This is the area now. This is the locations, right? In a 120, that's or 121 or 122. That's why it's open up, right? And then after that, what happens is this is going to keep going up like this, right? And maybe it goes all the way to 140 or something. And then it will come like basically like this, right? This is what it will come like this. And as this come like this, it's going to go and it's going to stay in higher pressure anyways. So this is, if you look at this one right here, right? This is normal, right? Aortic. But look at what happens if there is a gap, you see. Look at this. This is what, and the why this is, a lot of space is there. This is the reason why, because what? Left ventricle has to generate high pressure. So left ventricle, if you go all the way down from here, look at the left ventricle pressure. Left ventricle pressure is higher than what? The aortic pressure. So left ventricular pressure is a lot more greater than what? Aortic pressure, right? And this is a classical that you see the, you know, aortic stenosis, okay? So this is a gap. You gotta remember this. You gotta remember this, right? This is how they'll ask on your exams. Please remember that left ventricular pressure, it has to be a lot more greater than aortic pressure. So you see this gradient, all right? You see this what? Pressure gradient between the aorta and then also the left ventricle. This pressure is what? Left ventricle. Maybe it's like I don't know, I'll say 160 here. And maybe this aorta is like 120 here. Like now, when you subtract 160 minus 120, what is this? A 40 millimeter of mercury pressures of gradient that you see between the aorta and the left ventricle. Remember, left ventricle pressures and the aortic pressure should be like almost close to one another, right? It's supposed to be like this too, right? But now, like, look, there's a big gradient that you see because this green is showing what? Left ventricular pressure. And make sure you know how to draw this, right? Make sure you know how to draw this. It's a very, very important, because sometimes, like, that's how they'll ask on your exams. So whenever you look at this diagram, make sure you look at the gradient, look at the follow, okay? And I drew this so that way you can have a clear understanding. Plus, you gotta remember this graph also, because sometimes, they'll ask you like this, right? Now, after this, right? This is left ventricle is what? A lot more greater than left ventricular pressure, a lot more greater than aortic pressure, right? After this. Now we have to talk about what are the classical signs and symptoms that you can have because of the aortic stenosis, right? And this is what we're going to talk about. It's a very, very important concept, okay? And clinically, how they manifest, okay? Clinical manifestations with patient with the aortic stenosis is a very important, because that's how in your board exam they'll ask you clinical manifestation, right? Like one of the one. Like what is one of the most important things you should remember is that whenever it propels blood, that means that what happens, it has to generate a lot more higher pressure, right? Higher pressure in order to generate enough cardiac output, correct? That's what happens. Now think about it. In our diagram, what really happens is that there's a stroke volume is decreased, right? Which means what is stroke volume? What is cardiac output is equal to stroke volume times heart rate, right? If you decrease your stroke volume, then what, you decrease your cardiac output, right? Because cardiac output is directly proportional to stroke volumes. And cardiac output is the what perfusion tissue. That is what is bringing the what metabolic demands of tissue, right? That's what it's doing. So there is a decrease in cardiac output. That means that your body is becoming less perfusional, right? But remember, normally though, a lot of patients will show asymptomatic, because it will generate, even though there will be low cardiac output, but it's enough to not cause a problem, right? Usually problem happens in these people when they're doing some sort of physical activity, or they're doing exercise. Please remember that, because in your board exam, a lot of times they'll say like, okay, this person is running or walking, or he's running, or he's playing some sort of like physical activities there, right? There's a physical activities there, and this physical activity, right, that exacerbates your clinical manifestation. So there's an increase of physical activity, some sort of exercise, walking, like all right down here. There's a walking, or let's just say they're running, right? Walking, running, all this exacerbates the problem. And the way it exacerbates the problem is this: that when you run, right, what happens is that your skeletal muscles, okay, this is where you have to talk about, okay, let's just, what happens, like let's just say this is okay, look at this. This is the legs right here, right? What happens, the skeletal muscles, it requires extra oxygens, and blood perfusion has to be increased, right? When you're exercising, and it's because of that, whatever cardiac output you get, right? Whatever your cardiac output you get, that is actually taken by your peripheral tissue. Like for example, your skeletal muscles, your extremities, and your physical your extremities. Yeah, they will actually take those cardiac output, and it's because of really what happens is that the cardiac output that is actually getting to your brain, right? That is decreased, right? And when there's brain is not getting like a profuse oxygen, right? When the physical exercise, really what happens, that result into fainting, right? That result into fainting. And in medical term, we use this word called syncope, right? This is what SY and COP. This is what result, and this is what syncope is of fainting, right? Which is there's a transient loss of consciousness. That's what happens. Right? And these are very, very dangerous conditions. Okay, that's what result into when you're doing physical exercise, running and all. Now, second thing, this is one of the problems that happens, right? Second thing that can happen is that look, whenever you have to increase the cardiac output, right? Already the ventricle is what? Ventricle is hypertrophied. Plus there's aortic stenosis there. This ventricle has to work with extra, right? In order to generate enough cardiac output, especially when you're doing physical activity. And it's because of this, really what happens is that, the oxygen consumption, oxygen consumption, MbO2, this is increased, okay? What is it? Mitral, okay, so we talk about myocardium volume oxygen consumptions, okay? This is what it's called. So myocardium volume oxygen consumptions is increased, especially during some sort of physical activity, right? And usually, if you remember, there's something called aortic sinuses right here, right? Aortic coronary sinus, and they bring the blood right here, right? To the ventricle myocardium. And think about this, when there's already a decrease in cardiac output, but especially if you're doing exercise, right? And then really what happens is that there is even further decrease in a cardiac output which is normally perfuse your what? Ventricular myocytes, right? And there is a further decrease happens because whatever cardiac output is there, it is actually taken by your skeletal muscles. So there is a decrease or more further decrease in cardiac output that you see in the ventricular myocardium, right? And that result into, okay, that result into further, right? That result into decrease in myocardium volume, let's just say taking oxygen. So there's a reduce on what? Oxygen consumption is there, right? So the myocardium is taking less more oxygens. In normally, this is what it happens, like oxygen, there's a lot more increase in what? Myocardium volume oxygen consumption. That's what it is there. But really what happens, if they're not receiving oxygens, then what happens is that, so this is not receiving, okay? Not getting oxygen, and that results into what? Myocardium started what? Started producing a lot of these metabolites, right? And that results into something called angina, right? You're gonna have like a substernal, like a chest pain. That's what you're gonna see angina. And this is very, very important, right? So this is what, so your fainting is there, you have because there's increase in myocardial volume oxygen consumption is increased, but they are not gonna get more oxygen because whatever cardiac output is there, that is usually taken by your skeletal muscle, plus there's a decrease, and on top of that, as this myocardium vigorously contract, it also compresses the blood vessels, the coronary arteries, right? And that even add extra what? Or exacerbate your angina. That's what it does, right? That's what it does. On top of this, you gotta remember this, that like third is that, remember I said that there is this myocardium has become what? Less compliant, but there's an increase in what? Left ventricular pressure is there, right? Plus, as this pressure increases, left atrial pressure starts going up. That results into pulmonary venous congestions, increase what? Pulmonary venous congestions, which causes what? Which lead into what? Increase in what? Pulmonary capillary hydrostatic pressure, leading into what? Pulmonary edema. And now, what happens is that this is what leading to something called dyspnea. And what is dyspnea is that? Dyspnea means shortness of breath, right? Shortness of breath. And this is a classical symptoms you get. Look, you can, when you're doing, look at the classical every time. So when you're reading a clinical video, read it carefully. Usually they will say that 50 years old, running, or like some 90 years old, right? Doing some sort of physical activity or something, right? And that, those people come to a clinic or something, they win syncope, or they have exercise induced angina, or there's a dyspnea is there, or fainting is there, or syncope is there. So these are classical symptoms of what? The aortic stenosis. Plus, eventually, like it's going to lead into something called left, or all this comes to left ventricular failure, right? That's what is going to happen. And all the classical symptoms of left ventricular failure you started getting, right? These are classical symptoms, and you gotta remember this, okay? You gotta remember this. This is very, very important. Fainting, okay, angina, dyspnea is classical for this. On top of this, like these are 3 points you gotta remember. 4 is this, that whenever left ventricle contract, right? What really happens is this, it has to generate like higher pressure to open this valve, right? But as soon as when the aortic valve opens up, it produces this click, okay? This click, and this click is what is called ejection click, okay? Ejection click. Remember, these are, there are different names are given. Sometimes we call them ejection clicks, or sometimes we also call them aortic click, all right? And this usually happens, all right? There's an opening of the aortic valve, okay? This opening of the aortic valve produces this click noise, the noisy production that you get, that is called what? Ejection click, or we call them aortic click. Right? Or we also call them ejection systolic sound, okay? Please don't get confused, ejection click with the murmur that we're going to discuss now, okay? Now, 5th point you got to remember is that there is whenever this happens, right? Because ventricle has to contract so vigorously, right? I mean, it has to generate higher pressure, and what really happens, and that results into what? Turbulence, okay? That causes, they lead into murmurs, okay? Aortic stenosis leading to what? The turbulence of blood flow resulting into murmur. Okay, and then what kind of murmur you get is this. Remember, in a previous class, the intro to the valvular disease, I said that this what? Aortic stenosis is what? It is a systolic murmur, right? It is an ejection murmur, right? So this is what? So this aortic stenosis it's a systolic murmur, right? It's a systolic murmur. It is a systolic murmur, or we can call them it is an ejection murmur, right? We call them ejection murmur. Ejection murmur. And this is usually here where? Between because S1 happens in where? In the mitral valve closes, and S2 happens right here when the aortic valve closes, right? Now think about this, is a problem with the aortic opening, right? Whenever aortic opens, this is a problem is here. So it's because of the, you hear the sound between S1 and S2. That's why. So if I have to draw like this one, and this is very, very important, okay? And your board exam will love this. And this results into something called, this is S1 right here, okay? S1. And it results into producing sound like this. It goes up like this, shh, like this, and then it comes like this, okay? And you have this sound, this type of murmur. And here I'm going to make S2. And there's going to be S1 right here. All right? Now, what kind of murmur is this? Look, it's going up, going up, going up like this, right? It is called, this is called crescendo. Okay, what is this called? It's called crescendo. And it's going to come shh, like this. So this is what is called decrescendo. So this is a crescendo, decrescendo murmur, okay? So it is a crescendo. This is what it's called, it's going up. It's called crescendo. And then it's a decrescendo, a murmur you hear, all right? And it's best heard at the right upper, okay, second sternal border. It's a very, very important, all right? You hear a crescendo, decrescendo murmur. So sometimes you can write like this too. It goes up like this, okay, and comes down like this. So this is a crescendo, decrescendo murmur, okay? And you got to remember this. Please remember this crescendo, decrescendo murmur, or we also call them a diamond-shaped murmur, right? You can see this in other conditions too. And please remember this too. And there's a condition called hypertrophic obstructive cardiomyopathy. Even in that case too, you can hear crescendo, decrescendo murmur, right? So in order to distinguish between whether it's a hypertrophic cardiomyopathy or aortic stenosis, we have to do some sort of like a maneuver, and we'll talk about that because that is also very important. But anyways, now let's come back here. Systolic ejection murmurs, right, which is called crescendo, decrescendo murmur. This is the shape of the murmur, right? And it's usually here the right upper second sternal border. That's what you hear, right? And also there's ejection clicks that you get to hear. On top of this, you know, there is something that you have to remember. Is something called, you know, you write down here. There is also 6 point here. There's something called reverse or paradoxical splitting also you hear. We have to talk about what this is, and we also have to talk about the other point here is that, you know, whenever left ventricle hypertrophy, left ventricle, the pressure is very high, pressure is very high here, and the ventricle is what hypertrophy, right? So whenever the atria has to contract, it has to contract over the hypertrophied ventricles, right? So it's because of this, whenever atria contracts, it contracts over the hypertrophic ventricle, and it's because of this, you know, it produces sound, right? That sound is what is called S4 sound, okay? S4 sound. And usually S4 sound are a low pitch sound, right? It is a low pitch sound, and if you have to like auscultate to hear the S4 sound, right? Usually you can use the stethoscope, but not the diaphragm. Okay, low pitch sounds, if you're looking at this right here, right? Usually this is a diaphragm, correct? This is a bell. You can use bell to actually listen to the S4 because it's a low pitch sound, right? You can do that. Now, this is also you can hear. On top of this, right, you know, the 8 point is sometime, you know, because there is the ventricle has to, like, you know, the ventricle is contracting so vigorously, right, to eject the blood out, right? And that because they're contracting so vigorously to eject the blood out is because of this, right? If you actually touch the pericardium, right, you can actually feel something called, you know, your pericardium heave also, you can hear, like, heave. This is also, you can feel, okay? You can hear pericardium heave because the ventricle is contracting to eject the blood, and they try to sustain it, right? So that produces sort of like a heave on your pericardium, and that's what you get to hear. Now, look at what are the classical signs symptoms. Usually, okay, again, the people with the aortic stenosis comes to the clinic with asymptomatic, but if they do come to a clinic, or if they're doing some sort of physical exercise induced can do something called syncope, angina, and dyspnea. Very classical, okay? Plus, they'll have an ejection click, or they have a systolic murmur like crescendo, decrescendo murmur, which is the best heard at the second upper, okay, sternal border, right side. Please remember that. They'll have a S4 sound, which is a low sort of pitch sound. They'll have a heave, and they'll also have something called paradoxical splitting or reverse splitting. Now let's talk about what is this paradoxical and reverse splitting is this, okay? And for that, you know, I have to tell you guys about the physiological splitting. Now, you know, this is what you have to remember here. I'll make this as expirations, right? And I'll make this as inspirations, right? Now, first is what is your S1 sound, right? Let's make this S1 sound. This is S1, this is S1, right? S1 sounds heard when the mitral valve or AV valve closes, right? Atrioventricular valve. Now let's talk about S2 sound. And S2 sound normally have something called physiological splitting, right? So I'll write down here as a, all right, A2, all right? And I'll write down as a P2 here, all right? Normally. And really what happens is this, like, you know, let's, for example, during a expiration, right? Whenever you hear the S2 sound, right, you usually don't hear the physiological splitting. That you usually hear as a one sound. So I can denote this as like right here, like this. Okay? So okay, I'll make this in a different color. Your aortic valve closes, and then let's just say mitral valve closes. Or maybe like this, okay? So that's a time, right? Now during inspiration though, like what happens is this, the aortic valve closes a little earlier than when it comes about, let's just say, the pulmonary valve. And the reason why is this, that let's just say if I make aortic valve right here, okay? This is the aortic valve, okay? And normal should be here, right? I should draw here. But really what happens, during inspiration, what happens, your diaphragm contracts, right? It generates a negative thoracic or pleural pressure. And diaphragm contracts, and that pushes the abdomen to actually increase the venous return in the right side of the heart, okay? And when you increase the venous return in the right side of the heart, right heart cardiac output increases, right? That means that when the blood is flowing to the pulmonary trunk, your pulmonary valve takes a little time to actually close it because there's a blood flow is there because of the what? There's an increase in cardiac output in the right ventricle. So it's because of this, right? You usually see a little bit of time. Look at this. Look at this. There's a duration, right? The delay on closing is there. Normal should be here. No, this is a P2, right? Normal should be here. But look, there's a little gap here, right? So delay on closing on P2 valve, right? So this is what is called, let's just say, you know, physiological splitting, right? But in the, let's just say, aortic stenosis, right? What really happens is this, that if I quickly, let's just say, you know, actually, no, I'm going to make it in down here in the same graph so that way you can know. Let me make it this one. There's a, actually I'll make it here, all right? So because we're talking about paradoxical splitting, there's expirations here and there's inspirations here, right? And we'll make an S1 sound here like this, okay? But when you talk about, let's just say the paradoxical splitting, what really happens is that because in this place, right, really what happening here is that aortic valve, right, they have to generate a lot more higher pressure to what? To open the aortic valve, right? And because of that, really what happens is that when the aortic valve closes, aortic valve actually takes a little more time to close comparing to the, let's just say, comparing to the pulmonary valve, right? So usually what happens is that if I quickly make it, right? This is let's say this is a P2 here, and I'm going to make it A2 right here, okay? And what happens during expiration, what happens? Like nothing about. During the expiration, your lung, remember lung work as a reservoir. This is from your physiology, right? Usually holds like 500 ml of the blood or something like that, okay? Around that, or even could be greater too. But they hold, but remember the point being here is that lung play a role as a reservoir, right? And when during expiration, your airway gets smaller, right? Because you're expelling the air out, and then because of this, what happens to the, you know, when the airways are getting squeezed or becoming smaller, you also pushes the more blood from the pulmonary to the left veins, right? That means that really what happens is that during expirations, the venous return to the left heart increases, right? That means that cardiac output from the left ventricle increases. That means that there's an end diastolic volume of the left ventricle increases during expiration. That means the increase in cardiac output, that's what happens, right? Is because of this, really what happens is that there will be a further delay on closing the aortic valve compared to the pulmonary valve. So pulmonary valve closes what? Pulmonary valve closes right here. This is during expiration, so we're talking about expiration right here. And the aortic valve takes a little more time to close. There's a delay on this. So there's a look at this gap here. You see a gap here, right? Usually there should be no gap, right? There should be, usually you hear one sound. And then during an inspiration, really what happens is that, look, remember, aortic valve is closing right here, a little delay. Plus, you know, pulmonary, the P2, there's a cardiac output increases during inspiration, right? As we discussed here. That means that the P2 valve, you know, there's a delay, go a little close to this A2, right? It becomes close to the aortic valve. This is what happens. So this is during inspiration. Look at how P2 and A2, they're very close to one another. But during expiration, there's a P2 and A2, right? The P2 closes first compared to the A2, right? So during an expiration, what? P2 closes first compared to A2, right? So you see, if you're looking this way, I wrote this. I wrote A first and then P2 first during expiration here, right? In normal. This is showing normal, correct? But in the aortic stenosis, this has been completely reversed. There's a P2 closes first, and then there is a delay closing of the aortic valve, right? And this is what you see there in expiration, you see, okay? Please remember that. This is what you see in expiration. That means that this A2 and P2 closing, right, that has been reversed. That is why, sometimes we call this as a paradoxical splitting, or we also call this as a reverse splitting. That is what you see that in aortic stenosis, okay? Please remember this, okay? If you actually read your first aid book too, you can see this the paradoxical splitting, or there is also something called what? Reverse splitting happens specifically during expirations, right? That is why I made this, right? There's a delay in what? This P2 and A2 has been completely reversed, because first it should be A2, then it should be P2, right? But it has been reversed, okay? During expiration. And this is what is called paradoxical or reverse splitting. Now, look at how many things we discussed so far. Classical symptoms, right? Fainting, angina, dyspnea, right? There's a ejection click, okay? This soft S2 sort of a sound you can hear, two ejection clicks right here. I can say soft S2, which is basically that. Then there is a systolic ejection murmur, which appears as a crescendo decrescendo murmur, right? There's a paradoxical splitting you see. By the way, paradoxical splitting, you can also see this in a left bundle branch block, okay? I'm giving you. So left bundle branch also, you can see that. And you can see S4 sound, which can, you can hear the low pitch sound. You can hear the heave also, right? So these are the classical symptoms, signs, symptoms that you see that when it comes to the aortic stenosis. So always remember this, that, what leading to wear and tear, degenerative condition, calcium fibrous deposit into it, aortic crescendo decrescendo. You gotta remember this. You gotta remember this. You gotta remember bicuspid aortic valve degeneration, and you gotta know this left ventricular pressure. This is very, very important, right? Now, remember I told you about this, the crescendo decrescendo murmur, right? You can also hear in other conditions called hypertrophic cardiomyopathy, right? Right. So how do you distinguish between the, let's just say, this crescendo decrescendo murmur is caused by aortic stenosis, and it's not caused by the hypertrophic cardiomyopathy. And for that, you can do a maneuver, okay? And what kind of maneuver is this? Like, okay, this is other point that you have to remember here. And I will actually draw right here for the maneuver, okay? This is a maneuver, all right? The maneuver. And this is how we can remember this, right? Anything that increases left ventricular cavity, right? What can cause increased left ventricular cavity? Let's just write down here. Like, for example, if you want to increase left ventricle, that means that you have to increase your end diastolic volume, right? Or you have to increase your preload, same thing, right? Preload. And what are the causes that lead into what? Increase in preload. That means that there are conditions that has to do with, or any sort of maneuver, like let's just, not conditions. Like, for example, if you do a passive leg rise, right? If you you're sleeping right here and you leg rise, that means venous return increases, right? So you do a passive, let's just say, leg rise, you do this, right? Or let's just say you're doing squatting, right? Squatting, that provides a kink and venous return. You do or you do a hand grip, right? Any of this condition that you do, right, that results in increase in endoscopy. If you increase the inner, that means what happens? A lot of blood volume is there, right, in your aorta. That means the ventricle has to contract more vigorously to the extra blood they're receiving, right? It's because of this, right? It's because the intensity of murmur increases if there's aortic stenosis is there. So anything that causes what? Anything that increases the preload of this, right? If you're talking about aortic stenosis, right? The intensity, you're talking about intensity of the aortic stenosis, that goes up, right? By giving extra volume. But let's just say if you do anything that decreases the left ventricular cavity, right? Cavity. That means that you decrease the preload. You decrease end diastolic volumes or decrease preload. And this is usually you can do Valsalva maneuver, or you can do something called standing, right? If you do standing, what venous return decreases, so as Valsalva, right? Both the condition leading to what? The decrease in what? Venous return to the heart. If you decrease the venous return to the heart, what happens? The decrease of left ventricular cavity. size of the cavity that decreases, which means that the ventricle doesn't have to contract vigorously, right, to throw this purple out, because they're already receiving decreased volume of the blood, right, and that because of this specific aortic stenosis, right, that lead to decrease in your intensity of the murmur. You gotta know this maneuver, because sometimes they ask you on the exams, right, what can lead into increase of the intensity of murmur and what can decrease the intensity of murmur, and you gotta remember that. And I want you to think like this, right? Now, if you talk about the hypertrophic cardiomyopathy, exactly opposite happens. Like for example, hypertrophic oxygen cardiomyopathy, right? The murmur intensity, if you increase the end diastolic volume, right, by doing passive leg raising, squatting, and hand grip, that actually decreases the intensity of murmur. Okay, in the hypertrophic cardiomyopathy. And if you do, like for example, in the air, in let's say squat, like Valsalva or standing, that means there's a decrease in the venous return, right? If you decrease the venous return, that means there's a decrease in what? End diastolic volume. And in that case, in a hypertrophic obstructive cardiomyopathy, by decreasing the end diastolic volume, right, you increase the intensity of murmur, right? So this is how you have to distinguish. Make sure you know the maneuver of the aortic stenosis, right? Now, there's one more thing that I haven't told you about, and that's also this is one of the most important actually that you gotta remember when it comes to classical symptoms. Okay, they use this something called, okay, when they describe, right, they call this as a pulsus, right? You know, pulsus parvus at tardus. What does this mean? Okay, and this is very important. Okay, usually pulsus parvus, there is a weak pulse there, because remember, if there's a decrease, what is a pulse? There's a decrease of cardiac output, right? Usually pulse is generated when there's a, the arteries get elastic, right? Or get pushed out, right? And that produces sort of like, that you hear that as a heartbeat, right? And those are called pulse, right? But remember, if the cardiac output is decreased, then what happens is that there's going to be a weak pulse, right? So the pulsus parvus means weak. There's a weak pulse there, right? Plus that's at tardus. Tardus is a delay. The tard is a delay on up. So delay peak, right? So pulses are weak with the delayed peak. That's what it is. Plus, you should remember that, this murmurs, right? They can actually, you hear this sort of murmur. It's the loudest, the intensity murmur is the loudest at what? At the base, right? And the base is what? This is the base at the second intercostal space, right? And sometimes that can radiate to the carotid artery too. Right? Carotid artery is also something that you should remember. So please remember pulsus parvus at tardus, which is a weak, delayed peak, right? And also this murmur is best heard at the what? Heard at the base or second intercostal space, right? That's where is the best heard. And please remember, these classical signs and symptoms are most important for you to remember. Make sure you know the physical activity, make sure you know syncope, make sure you know angina, make sure you know about the systole, ejection murmur, crescendo and decrescendo murmur. This is the shape of the murmur. Make sure you know pulvus at parvus, weak and delayed, or tardy, weak and what? Weak and delayed peak. And also it can go to carotid artery. And make sure you know the maneuver. It's a very, very important. And you gotta know how to draw this diagram, right? You gotta know this. It's very important, because make sure you draw and you see the pressure gradients, all right? Because this is a classical, right? And aortic stenosis is one of the most common, and oftentimes aortic stenosis is actually tested during exam. That is why, I try to go very detailed and give you like everything that you need to know for your board exams, all right? I hope that I was able to help you to understand the concept of the aortic stenosis. So let's do a quick recaps on aortic stenosis. So if you're looking at this one right here, this is an aortic valve, which are made by three cusps. You can even see this right here. Now, what is the most important thing for you should remember is that there are primarily the two most common causes that can lead into aortic stenosis. One is age-related, that causes fibrosis and calcifications of the aortic valve, right? And this is where the collagen also get deposited. These are usually seen in people who are greater than 60 years old, right? And other one is seen in much more younger, less than, let's say, 55 years old. And usually you see there's something called bicuspid aortic valve, right? Now, you can see this clearly, right? There is an aortic stenosis, but this is caused by rheumatic heart disease, which can lead into aortic stenosis. But this too, you must know for your exam, all right? Now, if you're looking at this one right here, this is the first heart sound and this is the second heart sound, right? In between the first and heart sound, you see clearly there is there's a crescendo and there's a decrescendo murmur that you see, right? And it's a classical for aortic stenosis. And if you want to find the intensity of murmur or the aortic stenosis is best heard at this position, which is the second intercostal space, right? And which is where the right upper second intercostal space is where you can best heard the aortic stenosis. So this is where the base is. Now let me play how the crescendo decrescendo murmurs sounds, and you need to make sure you listen very, very careful, because oftentimes in your national exam they give you this murmur and they'll ask you to listen to it, so you need to know how to distinguish the murmur. Okay, so please listen carefully. All right. Now, we're gonna do and talk about this, something called here, if you see this left ventricular pressure is a lot more greater than our aortic pressure here, right? So it's because of this, usually when you talk about the aortic stenosis, as I already told you, right, it's called left ventricular pressure is going to be higher than what? The aortic pressure. You gotta remember this, okay? It's very, very important. Plus, you also see something called anacardic pulse, which is this is a name. Sometimes they give you this in our questions, okay? So make sure you know this. It's called anacardic pulse, also called pulsus parvus at tardus, right? And make sure you know what this means. So what is pulsus parvus at tardus means, or what is anacardic pulse means? You gotta know this, right? And these are classically, you see this in a aortic stenosis. And the way you describe the pulsus parvus at tardus is usually slow rising. It's a low volume or decreased volume corroded pulse, right? Or sometimes we also say the weak and what? A delay pulse, right? So these are this is how you can actually describe this pulse, okay? So sometimes the exam questions are as an answer choice. You might say pulsus parvus at tardus, or most commonly they use anacardic pulse, okay? And this is usually slow rising, low volume corroded pulse. Make sure you know this, right? Now, during when the ventricle is contracting, because there's an increase in resistance, right? So that means the myocardium, okay, this myocardium volume oxygen consumption, that's going to go really, really high. And remember, the peripheral tissue also, the myocardium, they also started releasing a lot of adenosine that results into a vasodilation because it requires a lot of oxygen, right? Plus the stroke volumes in this case will go down. But remember, if they ask you about the work of the myocardium though, like for example, stroke work, if they say, right, stroke work and stroke volume is two different things. If they say the stroke work, then stroke work will increase, right? Stroke volume decreases, but the work of the ventricle actually increases. And oxygen tensions of the myocardium also decreases because because of the what? Hypertrophy ventricle. Plus, especially if you're doing exercise, really what happens is that the peripheral tissue takes those cardiac output, and it's because of this there will be a decreased oxygen tension that you see. Make sure you know these arrows. It's very, very important. All right, and please go over the classical signs and symptoms which I already discussed in a pretty detail. All right, thank you.